So to introduce our guest expert today, Dr. Sarah Ball is a GP with special interest in menopause and also a member of the senior clinical team at Newson Health, the Menopause and Wellbeing Centre. Sarah is really passionate about helping women to understand their own menopause journey and also empowering them to be able to access the treatment that they might need. So just a bit of a caveat, Sarah is here to answer questions on all aspects of the early menopause and everything that goes with it, but we should say this isn't a medical consultation. So we do advise you, as always, to please consult your medical team about your own personal situation before you make any decisions on anything. So I'm going to hand over to Sarah to fill us in on lots of useful information, and then we will have plenty of time at the end for Q&A. So please do send in your questions if you haven't already. So thank you so much for joining us and giving us your time, Sarah, today. Over to you.
Thank you so much, Jo. That's very kind. I will just do the hardest bit of today, which is the technology. We go. Can you see that okay, Jo?
Perfect.
Brilliant. We're in business. Lovely. So yeah, thank you very much. Thank you for inviting me. It's so nice to be able to do things like this. As Jo said, we are extremely passionate about helping all women, and by all women we mean even those of us that are challenged with sort of additional health issues which make or seem to make the situation a bit more complicated. Just by a bit of extra introduction so that you understand my role. So I am a GP with a specialist interest in the menopause, and this is the clinic that Louise Newson, my colleague, my boss, first set up. So the vision really is that we are a team of predominantly GPs, but also nurses, pharmacists, we've got pelvic floor physiotherapists, we've got people that can scan for us, we've got nutritionists, we've got psychologists. We have a whole team of people that are really passionate about helping people with the menopause. Unfortunately, this is something which has had to be a private venture, which is not something that sits very well with any of us, but unfortunately the NHS is not yet ready to kind of embrace the menopause as holistically and as well as it needs to be done, but we will get there. So I'm quite a visual lecturer. I use quite a lot of pictures. And so this is one of my two favourite book covers. And it actually happens to be a novel that covers the menopause, but actually I just love the front cover because actually the answer to the question, how hard can it be, is it can be for some people extremely hard. And so having the right information and support is a really crucial part of the journey. So it's great that you're listening today because obviously you're on this journey. And so what I'm aiming to do over the next kind of 30-45 minutes or so is to give you an overview of what the menopause is, but obviously with a specific sort of a leaning towards where most of you guys are probably at with it, which is often at a slightly different place to the general population. We're going to talk about the health risks that are associated with the menopause and most crucially how to manage it, and that will include but not exclusively about HRT. And then, as Jo said, there'll be time for some questions. And this is the Haynes Manual of Menopause, which is also written by Louise Newson. So that's a really good sort of book as well that covers all the salient points about menopause. So menopause, as you I'm sure well know, is about our last period. In effect, that's what it actually means. And this is a cake that my daughter made a few years ago at Easter, and it's obviously an Easter cake, but in my world that is an ovary pouring out its eggs, which we do over our reproductive life. And if you reach a natural menopause, then your eggs just gradually have dwindled away, there's none left, and that usually happens at about the average age in this country of about 51, but for kind of 90% of us it will happen at some point between the ages of 45 and 55. So it's kind of it's not necessarily pleasant, but it's a gradual kind of decline into the menopause. There are, though, about 10% of women will experience a natural menopause before the age of 45, and we call that an early menopause. And then about 1% of women will experience what we call premature ovarian insufficiency. So that actually means that their ovaries have stopped working before the age of 40. And as I say, in a natural menopause, we have what we call a perimenopause. So it's this horrible roller coaster of hormones, which can last anywhere from a couple of years up to about 10 years, where our hormones are up and down like a toilet seat, and that can make us feel dreadful, and it can be quite difficult for us to detect what's going on. But what we need to contrast that with is an induced menopause, so not something you've reached naturally, but something that has very suddenly happened. And as I'm sure you're aware, for most women, that either comes about through surgery from having your ovaries removed, or it can come about from treatment for medical conditions, often cancer treatment. So things like chemotherapy, radiotherapy can damage your ovaries so that they stop working fairly abruptly. So the main thing to remember is it's a sudden change, and it's really crucial that women understand, well, one, the difference between a natural menopause and an induced menopause, and how important it is to plan ahead. One thing I just want to say that I should have said at the beginning is that I know that not every single person that experiences a menopause necessarily identifies with as a woman, but for the sake of simplicity, I do use the word woman, which I hope is okay with everybody. So what I kind of want to get across really in this rather alarming picture of me is trying to encourage you, when you're thinking about the menopause, to not solely focus on those bits of our bodies which are hidden behind a bikini. I think most of us think of the menopause, because it's the end of our reproductive years, as being only really to do with those parts of our bodies that are under a bikini, but actually it's about all of us. And so I wasn't brave enough to put any more revealing pictures of me in a bikini, but I would like to point out that I am actually reading a manual of the menopause whilst on that lilo, so I was kind of working on my holiday. So it's about, when you think about your menopause, although in your particular situations, it's highly likely that you need to pay a lot of attention to what's going on in your pelvis, and particularly your ovaries, and also to very carefully consider breast health, but we have a whole body, not just a bikini. And the reason that we really need to think about the whole body is because the menopause affects the whole body. So there is not a type of cell in the body that isn't affected by estrogen. So we need to think about it from our brain's point of view, and our brain obviously has so many functions. It deals with our temperature regulation, it deals with our mood, it deals with our sleep cycle, our memory. We need to think about things like our liver, which deals with a lot about our metabolism and how we make things like cholesterol, and cholesterol is actually our building block for all our hormones. We need to think about our bones and our skeleton. We need to think about things like our skin, and whether we're getting itchy or rashes, things like the heart health, how our blood vessels are, as well as our typical reproductive organs. So we really need to think about everything, and the menopause is not a temporary blip. That is very much portrayed in the media really, and society, that the menopause is a short term, maybe a few years of a few hot sweats and flushes, and if you can soldier on and get through it, you're out the other side. That is simply not the case. Once you lose your hormones from your ovaries, then, which is why we should be thinking about this as a long-term thing, not a short-term blip. And what is really important as well, I think, when women often say to me, because obviously I talk about the menopause all the time, is, oh, why do you keep harping on about the menopause? Why do you keep harping on about the HRT? Our great grandmothers never had to worry about this sort of stuff. Why is it all the fashion now? Well, that is because we live longer than we used to. So if we rewind 100 years back to Victorian times, we barely lived beyond our menopauses. So most women died within a few years of 51. So it didn't really matter that much about how the menopause affected you. We live longer now, which is great. That is, progress in terms of medication and science and public health and hygiene and things. We live longer, but our hormones have run out. So if we really want to tackle the second half of our life properly and to the best of our ability, we need to deal proactively with our menopause. I think of it very much, I'm very much about analogy. It's like half time in a football match when you get to your menopause. Admittedly, if you have your ovaries removed, it may come at even before a natural half time, but you need to use that time at half time to plan, what do you want to do for the second half? How are we going to win this match? And use your rest time, your talk time, your refueling time to work out how to move forward. So why do I harp on and on about the menopause? Because basically all of us that have ever had ovaries will go through a menopause, however that comes about. And most of us, 80% of us, will have symptoms. And for a quarter of us, those symptoms are severe. So they really can be life changing. We know that about a quarter of women end up taking time off work, and actually then half of that number again may not return to work or may have to reduce their hours or change their role. And what's really, really sad is the vast majority of women don't actually realise that their symptoms are to do with the menopause. They just presume that that's become their new normal, and that is wrong. So we need to educate all women in order to improve their life and their family's life and sort of society's life. So without meaning to teach you to suck eggs, what are the symptoms of the menopause? Most people presume it is just hot sweats and flushes, and yes, they do affect many women and they can be very debilitating, but they are not the be all and end all, and they are certainly not the reason why most women visit our clinic. Most women struggle with lots of different symptoms. It's like a constellation of symptoms which is particular to any given woman. So most women don't sleep properly after their menopause. Their tiredness levels ramp up hugely. If a woman is having a natural menopause, her periods may go completely haywire. Joint and muscle pains are quite a common one, which no one understands. We see a lot of women diagnosed with things like fibromyalgia and going off to see rheumatologists and orthopedic surgeons, and actually it's their menopause that's the issue. Women's hair changes and starts to thin, skin often changes. That's usually to do with diminished estrogen levels. Often women start to feel palpitations, and therefore they're often sent off to see a heart specialist when that's not what they need. And migraines are also quite a common thing, which tends to occur mostly with hormonal fluctuations, but they can be very debilitating for women. And our body shape changes around the menopause. It's not our fault, it's a metabolic phenomenon caused by low estrogen levels. And often women feel very itchy all over and have no idea where that's coming from either. So that's like the physical symptoms. I think the biggest issue for women, if you look at, the whole picture, tends to be the psychological symptoms, because it changes us in terms of our personality and how we tackle problems and how we interact with those people around us. So I think the commonest problem is probably anxiety, but many women experience a low mood. They kind of lose their joy in life. It's sort of irritability, rage becomes a thing, and our brains go so foggy. It's like we're trying to make the grey matter work and we can't multitask anymore, we can't focus, we can't concentrate. Our memory goes to mush, we leave our phone in the fridge, we forget to pick the kids up from school, and we just generally start to doubt ourselves, to lose confidence, to lose that sort of self-esteem, and our motivation to do anything, including getting ourselves better, also then can start to wane. And there's also the symptoms that a lot of people will avoid talking about if they possibly can, but they are so important to talk about, because if I don't talk about it, no one else is going to talk about it. So we have estrogen receptors in our vaginas, in our pelvis, in all the muscles around our pelvic floor, and in our vagina and around our vulva. So we can start to get problems with our waterworks. That's not just a normal part of aging, it's part of losing our hormones. We can often get problems with dryness of the vagina, which makes it sore. It can hurt to have sex, it can hurt to ride a bike, it can hurt to wear a pair of jeans. This is not, this is not solely the issue of people that are still in a sexual relationship. And that obviously will put anybody off having sex if they're having those problems, and that therefore can cause more problems with self-esteem and problems within a relationship. So it's really important we talk about these. And this is my my two favorite books. So the one I showed you at the beginning, and this is my second favorite book, Me and My Menopausal Vagina. It is, every woman on the planet should read this. It's fantastic. And the picture beside is the author Jane Lewis and myself doing an Instagram live, which I think we must have done it in, I think it was June, maybe July, where we covered every type of sort of problem to do with the genitourinary system. So if you want any information about that, you could look her up on Instagram. How long can the menopause symptoms go on for? It's not temporary, like I said before. And because there's so many symptoms, all the symptoms last a different amount of time for any different woman. So you can't give an absolute answer. But on average, a woman will experience symptoms for about 4 to 7 years. But actually, unfortunately, about a third of us will experience problems beyond the age of 60. And about 10% of women, sadly, actually will have symptoms for the rest of their life unless they do something about it. And the other really crucial thing to mention there is that women that have a surgical menopause usually wake up the next day and they're landed with all the symptoms. So it is really sudden. And if you have your ovaries removed when you're in your late 30s, that is an awful lot of time that you need to deal with and to get rid of those symptoms, if at all possible, so that you can actually live a proper, fulfilling and enjoyable life. So symptoms of the menopause can be horrible and debilitating. Occasionally women don't experience symptoms, which is good in a way, but also slightly worrying to me in that those people may not necessarily seek help. So it's actually almost as important to know whether you do or don't have symptoms. But what's also really important to think about is not just the here and now, but what is going to happen long term. There are silent risks to the menopause which will go on for much longer, and it affects, as we already looked on that map of the body, it affects all our blood vessels and therefore our heart. It affects our bones. Also, the main driving force of our brain cells is actually estrogen, and so we are more likely to have problems with dementia after the menopause. As I said, we tend to gain weight after the menopause, and that usually goes on around our middle, and that's because our body senses that estrogen's gone, and so it goes into a defensive mechanism of trying to make a little bit of its own estrogen, and the only way it can do that is to make more fat cells. So that's why we tend to become overweight after the menopause, and that then increases our risk of diabetes. We also, because we're not having mood stabilizing effects of our hormones on our brain, we're more prone to depression. And as I said, the genitourinary symptoms are really common. Almost all women will have some genitourinary symptoms at some point in the rest of her life, unless she does something about it, and they almost never get better on their own. So it's really important to tackle them. And what's really important is that if you reach a natural menopause, say at 51, you are at risk of all these things as your life progresses. Unfortunately, the earlier you reach your menopause, the worse the risks of these things are. And that's why it's really important, if you are having your ovaries removed, and especially if that's below the age of 45, and even more if it's below the age of 40, and even more if it's any younger than that, these risks get higher, and therefore it's even more important to consider your options for replacing hormones ideally. So how can you manage your menopause? The most important thing is to know about it, and you're already obviously ticking that box by learning today. Talking to others, actually, other people are going through this. They're just all at different stages of the journey and all suffering in varying different ways. So use your friends wisely and get information from them, and use charities like this to get more information. We need to think about lifestyle, because that is extremely important, and I will come back to that in just a second. We need to talk about HRT, because so many people don't understand that properly, and I will also talk about the alternatives to HRT. So lifestyle is absolutely crucial. We should all be paying attention to our lifestyle all the time. It shouldn't just happen at the menopause, but the menopause is quite a good time to kind of pause, think, rejig, reprogram and decide, right, what can we do now which is really going to improve my health. And making lifestyle changes does help reduce the symptoms of the menopause, and it does help to reduce long-term risks of the menopause and health in general. But the really important caveat is that you can't entirely lifestyle your way out of the menopause. Unfortunately, you can do a pretty good job, but it will not make up for those lost hormones. And so women shouldn't sort of be beating themselves up and trying to live the perfect healthy life and still struggling. It probably means you're not having enough help. So diet is really important, and I will briefly come back to that in a second. This is another one of my favorite books here, the Happy Hormone Cookbook, which our nutritionist Emma has written. It's got some lovely recipes in which are very much helpful for women in the menopause. Exercise, really, really important for all aspects of our physical, psychological health. We should be a bit more mindful when we're at the menopause that we don't have to do quite such high intensity stuff anymore if we don't want to. We actually benefit a bit more around the menopause from slightly less high intensity stuff, more sort of yoga, Pilates, weight bearing, walking. You don't have to sort of absolutely kill yourself trying to run marathons if that part of your life is slightly behind you. We need lesser stressing exercise after the menopause. Stopping smoking, crucial if at all possible, and reducing alcohol, really, really important, and we'll come back to alcohol in a minute as well. Having adequate calcium in your diet is very important for your bones. Most people that have a varied diet and that aren't dairy free, so that aren't vegan, will usually have enough calcium, but you can get an app on your phone which very easily calculates how much calcium you have. You only need to supplement calcium if your levels fall below the recommended levels. Vitamin D is different. You won't take enough of that in through your diet to be enough. It's impossible. You really get it from the sun, and we don't even have enough sun in this country, unfortunately, most of the time. So we should supplement vitamin D. And sleep and relaxation is a very important lifestyle thing. It's not being lazy. We need sleep and relaxation to actually repair properly. So another favorite book of mine, The XX Brain. This is all about, it's predominantly about how lifestyle and hormones affects our risk of dementia, but it's a really brilliant read. Essentially, for nutrition point of view, as I said, we will gain weight around the menopause unless we tackle it. And predominantly, it's not about fad diets. It's not about trying to lose weight quickly. It's about finding something sustainable for the long term. So Mediterranean style diet is by far the most important things. It's having whole grains, it's decreasing our saturated fat intake, but keeping up unsaturated fat intake. It's keeping up our fiber, it's decreasing our alcohol, it's trying to reduce any refined sugars, and having lots of sort of essential fatty acids, things like extra virgin olive oil, chickpeas, oily fish, that sort of thing, that are good for our brain health, our hormonal health, and our general health. We should also really consider our gut health. Our gut is like the waste sewage pipe of our house, in effect. If that is blocked, it doesn't matter how good processes are inside your house, it's going to be spoiled if the rubbish can't get out. So make sure your gut health is also thought about. For the most part, supplements aren't necessary aside from vitamin D, but there are a few supplements which can be helpful for women considering their hormonal health, which I can talk about if anybody wants to. So HRT is usually the $64 million question in these sorts of situations. And unfortunately, most of us, me unincluded, don't know enough about HRT to actually make a reasoned decision about it. Most of us, unfortunately, have been trained inadvertently by the media, which has sent out wrong messages, unfortunately, for about 2 decades now. So it's really important that people have the right information. If you've got the right information, you can make a choice which is right for you. And unfortunately, healthcare professionals aren't always that helpful either. There's a lot of very old myths and attitudinal changes that need to change, and education is the key to that. There are all sorts of HRTs available. HRT has actually been around since about the 1950s, 1960s, and there have been all different types during that time. And that often is where a lot of the bad headlines and the bad views about HRT comes from. We get caught up on what happened with old-fashioned HRT, and we forget that actually time's moved on and there is a lot better stuff out there now. So this is just a picture of, this is just a few, but this is kind of what I call the best stuff, okay? And by best stuff, we call it body identical HRT. So the name is kind of on the tin. What that means is the hormones in those boxes of HRT are identical to what was in your ovaries if you no longer have those ovaries, or your ovaries you've kind of shriveled up. So it's not a synthetic copy of your hormones, it is the identical stuff. And actually body identical hormone actually comes from yams, so the root vegetable yam. So it's actually very natural, and a lot of people use that word natural and they often use it in the wrong way, but essentially the newest type of HRT, body identical, is the natural way of replacing what you've run out of. In the same way as if you had an underactive thyroid, you would replace it with the hormone that you've run out of. It is really that simple. There's lots of different types of getting those hormones into your body. There's things like gels and patches and sprays, which are the common ways of getting estrogen into our body. That's the safe way, totally safe way of getting estrogen into the body. Estrogen is effectively the hormone that we miss the most when we don't have our ovaries anymore. It's the one that helps most with the symptoms, and it's the one that helps most with our long-term health. But if we retain our wombs, or if we've still got a uterus, so you haven't had a hysterectomy, you then need some progesterone, because that is given to protect our womb so that we don't get cancer in the lining of the womb at a later date. And again, there is a natural form of that as well. There's only one type in this country, so it's easy. It's the box in the middle at the bottom called utrogestan. But sometimes we use things like a Mirena coil, for example, which can also be used as progesterone part of the HRT. So there's those two main hormones, which are the thing that we normally would start with, and for many women give an awful lot of symptom relief and an awful lot of future health improvements as well. But it's not a one size fits all, and different women need different doses, and different women absorb different types of HRT in different ways. So it's kind of trial and error. Sounds a little bit kind of blasé, but you know, not everything suits everybody, but we can almost always find something that suits an individual. And HRT, normally when we talk about HRT, we're talking about systemic HRT. So in other words, the hormones will go all around your body. But there is also what we call localized HRT, which I will also come on to, and that's when we just want to deal with any vaginal or bladder type issues. And a really important thing to know about, especially as women who may or may not have your own ovaries, is thinking about testosterone. So testosterone is also a really important hormone for women. We had plenty of it actually until most of us were in our mid-30s, and for most of us with a natural menopause it starts to decline in our late 30s anyway. But when your ovaries are removed in surgery, you lose your testosterone overnight, and we can really miss that. We make less testosterone than a man, but it's still really important to us as women. It really helps with our energy levels. It really helps with our brain function and our kind of focus. It helps with our physical stamina. It can help regulate our mood even more than just estrogen on its own. And it can be a real game changer with improving sex drive. So libido really responds well to testosterone. So it's really important that women, especially women that have had their ovaries removed, know that that is an option to add to your HRT. It's not always the easiest thing to access, but obviously we can talk through the ways of trying to get around that difficult conundrum. So why would we take HRT? Because it is the single best way of getting rid of symptoms. That is not in any doubt. It also markedly reduces our risk of osteoporosis. So it's, you know, in terms of preventing fractures in our later life, it's hugely beneficial. It reduces our cholesterol. It actually reduces our friendly cholesterol, unfriendly cholesterol, and raises up our good cholesterol. So it actually makes the balance of our cholesterol better, which then helps our blood vessels even more. It lowers our risk of diabetes. It therefore, all of that added together, lowers our risk of heart disease. And HRT used in this body identical form does not raise blood pressure. That's another common myth about HRT. And HRT then can reduce our risk of dementia. And again, the earlier you have ovaries removed, the more benefit you'll get from replacing your hormones in terms of preventing future problems with our brain health. And we have this term in medicine called all-cause mortality, which is just a very boring way of saying your risk of dying from anything. And that goes down with HRT. No matter what type of HRT you use, it goes down. If you use the best type, your statistics are even better. So it really does kind of sound like a no-brainer, I think. Why would anyone not use HRT? But of course, as we all know, the elephant in the room is always, well, what about breast cancer risk? It's going to give me breast cancer. Why would I go to all this trouble to try and prevent my risks of breast cancer or ovarian cancer or whatever cancer we perceive that we're at risk of? Why would I go through all that and give myself HRT? Aren't I just undoing all the good? That is what most women, unfortunately, are led to believe, and that is simply not the case. Almost every headline, in fact, I would say all headlines that you could ever have possibly seen since 2002, when this very dodgy trial called the WHI came out, will have been based on wrong information, very biased information, and all based on old-fashioned HRT. So don't read any of them. You will not get the right information for yourself. The truth about breast cancer and HRT is that the risk of breast cancer associated with HRT is always much smaller than almost anybody would think. And put very bluntly, if you look at all the evidence that we have to date, it would suggest that HRT may cause breast cancer, but equally it may not cause breast cancer. Literally, the jury is still out. If you look at all the data, there is no confirmation that HRT causes breast cancer. And just as a very kind of a similar analogy, if I said to you, does smoking cause lung cancer? I would very much think all of you say, duh, yeah, of course. That's because it was proven very quickly, very easily, in huge numbers. You know, there was no doubt. We've been having this argument about, does HRT cause breast cancer for 50, 60 years, and we still don't have an answer. That in itself says enough that there can't be a strong link, otherwise it would have been proven by now. So if there is an association between breast cancer and HRT, it seems to be a very small, rare link. Now, when I show this slide, I am talking about the general population here for a second. So basically speaking, in the general population, breast cancer is very common. We used to say that 1 in 8 women will get breast cancer in their lifetime. Actually, it's probably moving more to about 1 in 7 now, unfortunately. Now, there are some things that we cannot do about our breast cancer risk. And there are some things that we can do things about. So what we essentially need to concentrate on is what can I do something about? You unfortunately cannot change the number of candles on your birthday cake every year. So we stop worrying about aging. You can't change that, but our risk goes up as we get older. Our family history is important, and it's especially important for people listening today because of the genetic links, but actually most people that have a family history of breast cancer will not get breast cancer themselves. It's just a function of the fact that breast cancer is so common. You only have to have 8 close female relatives in order for one of them statistically likely to have breast cancer themselves. The things that we can really change are our weight, which has a big bearing on our breast cancer risk, how much alcohol we drink, and whether we exercise or not. So we should be concentrating on those things, and those 3 things highlighted in pink are all, we're much more able to tackle them if we feel well in ourselves. And so HRT may enable us to be able to change those risk factors, which then have the biggest impact on our future risk. Breast cancer and HRT also is a bit more complex than, you can't lump all HRT together and make one conclusion, because there's different types of HRT. So there is actually no increase in the risk of breast cancer in women who take estrogen only HRT. So any woman that's had a hysterectomy, so in other words, their womb is gone, does not need progesterone, and therefore she will tend to take estrogen only, and that can include testosterone. That's not good. So if you take estrogen only, we used to think, well, it doesn't seem to increase your risk of breast cancer, so it's probably neutral. But actually, the more and more information we have actually suggests it's actually protective. So estrogen only HRT will reduce your risk of breast cancer. And we've just had data that came out in the past sort of 12 months, which looked at women that used HRT, estrogen only, for 20 years after having a hysterectomy for any different kind of reason. And they had a 20% less risk of getting breast cancer. So it would appear to be protective. So that's really important to know about. Women who are young, so any woman that experiences a menopause for any reason before the age of 45 and then replaces her hormones, does not increase her risk of breast cancer. Okay, because really you're only replacing what you abnormally lost anyway. So you're not putting yourself at an increased risk. If there is a risk, it seems to be associated with the combination of estrogen with a progestogen. So for those people with a womb that are over the age of 45, that are taking HRT, there appears to be a very small risk. And the risk only seems to be about the level of an extra 1 case of breast cancer in 1,000 users per year. So it's actually, that's obviously significant for that one person, but if you look at the statistics, that's actually quite a small risk. But that really is based on the old type of progestogens that we used to use sort of 20 years ago, the synthetic types. As I've said already, we've got better stuff now. We've got the natural form of progesterone, and we know that the risk with that is less. And the risk may be zero. We just don't fully know yet because it's not been around as long as older HRT. We know that there's no increase in the risk of breast cancer if you use the natural form of estrogen and progesterone for 6 years, and the risk would appear very small after that, if at all. It doesn't appear to reach statistical significance. Okay. And the other really important thing, without meaning to sound too kind of grim, is that actually there has never been any study or evidence that shows that even if your risk of being diagnosed with breast cancer goes up a tiny amount with some types of HRT, the risk of dying from breast cancer doesn't increase alongside it. So obviously there is a big difference between being diagnosed with a cancer and actually dying from it. So most women that develop breast cancer whilst on HRT would have got breast cancer anyway. The HRT was just kind of an innocent bystander. Okay. And I don't know if you can actually see this on your screens. It may or may not be a bit small depending on the size of your screen. This is a really useful tool, but again, it shows, this is basically based on, if you imagine 1,000 women or all aged somewhere in their 50s who are watched for 5 years. The 23 little blue people that you can see in the top line, that is the number of women that would be expected to develop breast cancer over that 5-year time period. The line under it is those women that the extra 4, those pink people there, that's the extra 4 people that would get breast cancer over that 5-year time period if they used combined HRT, and that's any type of combined HRTs. That includes the old stuff. So that comes out at the same number as I said before. That's 1 woman per 1,000 per year, so it's a small amount. The next line down is the women who, the green women is less people. So that's people taking estrogen only HRT. So you'll see that number that would have got breast cancer has actually got smaller, as I said. The next line down is actually women who use the combined oral contraceptive pill for their contraception. So actually there's no greater risk with HRT than there is from the contraceptive pill. The next line down shows what happens if you drink more than 2 units of alcohol per day. So actually slightly more women get breast cancer if they drink 2 units of alcohol per day than if they use HRT. The next line down is the few extra women that get breast cancer if they smoke. The real game changer, I think, for most women is the next line down. Look at all those extra women, the numbers pretty much doubled, and that is the extra women who are overweight who get breast cancer. So if you can tackle the weight issue, that's where you get the big differences. And the last line is women that do regular exercise will be less likely to get breast cancer. So it's just a visual way of trying to show what I've said. And just the third visual way is just remember 2 glasses of wine every night increases your risk of breast cancer more than HRT can do. And many women drink to numb their symptoms of the menopause. Okay. So just to be a little bit specific for you as viewers, and obviously you know probably a lot more about this because you live with this, but basically many of you may have or be considering having your ovaries removed as a risk reducing procedure, and obviously this leads on to an early menopause. So the current guidelines suggest that HRT should be used until the natural age of the menopause, so to about 51 years old, unless that woman has already had breast cancer herself. So it really should be, as I see it, if a gynecologist tells you he's going to remove your ovaries, then I think he should also be telling you at that same in the same sentence that you will have HRT from the day of your surgery and you can take it until you're 51. You know, that should be the default, really. And ideally, if you were to use the body identical HRT, that means any risks, which, as I said, are very, very small, are completely and utterly minimized. There is a bit of a tricky issue about, well, so should a woman having their ovaries removed as a risk reducing procedure, should they have a hysterectomy as well? And I think that's a really good question, and I think every woman should be allowed to have that kind of dialogue with their surgeon, mainly because if there is a very tiny risk, well, there is the risk with combined HRT is just slightly higher than if you have estrogen on its own. Therefore, I think a woman should be allowed to make a choice as to whether she chooses to have a hysterectomy at the same time or not. There are pros and cons of both. A hysterectomy is a bigger operation, but I do think it should be part of the conversation. And obviously, women may then also, depending on their genetic variant, may also consider a risk-reducing mastectomy, which then, of course, takes the risk of breast cancer down substantially because there is almost then no breast tissue left. Women that have had a history of breast cancer are usually told that HRT is an absolute no-no. And to be fair, that is correct in that it should not be the first thing to think about, because a lot of breast cancer is what has hormone receptors in it, and therefore may be you know, it's not the first thing that you want to do. You spend a lot of time with your treatment for breast cancer obviously trying to block estrogen, so you wouldn't, as a knee-jerk reaction, take more estrogen. But it is a conversation and it is a choice that any individual woman can make. Women that have had breast cancer tend to have a even harsher menopause because of the way that their menopause has often come about through their treatment. So symptoms can be absolutely dreadful, and quality of life is absolutely key. So I see many women that have had breast cancer or have breast cancer who are struggling hugely, and we will have a conversation about all her alternatives and choices, all the pros, all the cons, and we talk about the fact that actually there is no compelling evidence yet that says that any woman with a history of breast cancer that takes HRT afterwards is any more likely to have a recurrence of her breast cancer. And therefore we have to bring it back to quality of life all the time. But regardless of that woman's choice about HRT, having vaginal estrogen is always an option, even if you've had breast cancer. Another common question or myth that we often get asked about is, does HRT cause ovarian cancer? And this has also caused a lot of confusion over the last kind of 20 odd years or so. If you actually look at all the evidence to date, there is no convincing evidence that use of HRT will increase your future risk of getting ovarian cancer. There's kind of different types of study that are done in medicine and different qualities. So some are a bit rubbish, you kind of don't believe them, some are kind of medium, some are actually good quality studies that have tested a hypothesis properly. And the best type of study that was done on this did not show an increased risk of ovarian cancer in women that had used HRT. There have been sort of slightly lesser quality studies, what we call meta-analysis, that have possibly shown an association with risk, but it's a very small association. And somewhere I've put 5,000, but I've seen anywhere between 5,000 and 8,000 women would have to take HRT for one extra case of ovarian cancer to be diagnosed. It's a very small risk. And I also see women that have had a history of ovarian cancer. It may have been many, many years ago, it may have been relatively recently, and it may have been very early stage or later stage, and all different types of ovarian cancer. Again, there is, if you look at all the evidence, there is no evidence that using HRT after or with a diagnosis of ovarian cancer increases the, or should I say, makes the outcomes worse, so that you're no more likely to get a recurrence and you're no more likely to die because of your ovarian cancer if you use HRT. And there have actually been some studies that show an improvement in survival rates. And that kind of makes sense to me, because I see many women that are completely flawed with menopausal symptoms, and they may have had a history of ovarian cancer, and they have become extremely overweight, extremely stressed, they're not eating, sleeping, they're existing really, if that. And so if you can take some of those symptoms away, if not all, and make her feel better, you can understand then her resilience for you know, tackling her underlying ovarian cancer is going to be greater. So you know, it's really important that women know what the evidence shows. Quality of life will always out-trump anything else anyway. There are possibly, it does get a bit intricate and complicated about the different types of ovarian cancer, and that is quite difficult to kind of weed all of that out in the in all the data. But obviously on an individual case basis, when we're talking to women, we'll obviously go through their kind of specific issues. So in terms of, oh, forgive me one second, there we go. In terms of alternatives, lots of women ask about alternatives because they consider alternatives safer and more natural. And I hope already I've helped to dispel some of those myths, because just because something is natural does not necessarily mean it's safe. Heroin technically is natural, it comes from a poppy, that doesn't make it safe or good for us. Unfortunately, anything that you can buy over the counter does not have a strong evidence base to suggest that it's helpful. So anecdotally, some women will respond with some symptoms. Usually it's only the symptoms of hot sweats and flushes, which many women would argue is not their biggest issue anyway. So I don't routinely recommend anything over the counter. I haven't written it on this slide, but also don't get muddled up with, when I've talked about body identical HRT, don't get muddled up with what we call bioidentical HRT, which is different type, it's non-regulated stuff, so don't go down that route. There are some prescription medications that can help the symptoms, but the symptoms they help are usually, again, only the hot sweats and flushes, and they're usually the type of medication that are usually used for either anxiety or depression, or epilepsy, or sometimes some old-fashioned blood pressure medications. They can be helpful in a select few number of people that choose not to use HRT, but they're not brilliant. They have their own side effects and risks, and they don't deal with the long-term risks of menopause, and they don't deal with all the symptoms of menopause. So they're not a kind of a really good second choice, to be fair. Some women benefit from CBT or hypnotherapy for things like hot sweats and flushes, but it's usually only a short-term help. Using estrogen in your vagina, if you're having problems with vaginal dryness, soreness, pain or with sex, bladder issues, can be really, really helpful and life-changing, and it is completely and utterly safe. You don't absorb enough of it to have any meaningful effect on the rest of your body. So anybody that has a vagina can use vaginal estrogen. Don't read the leaflet inside the packets, because they're completely wrong. They talk about old-fashioned HRT and they make you feel there's a risk, and there is not. They are completely wrong, those leaflets. And women should be advised about the simple things as well, like using a nice brand of lubricant and moisturizer to keep things well lubricated down there, which you can use alongside vaginal estrogen as well. That's all sorts of different, there's lots of different types of vaginal estrogen. So again, one size doesn't fit all, but there are options. And finally, I've talked long enough, we kind of take home messages. So hopefully some of that will have kind of resonated with you. The menopause is not a short-term thing, it's a long-term hormone deficiency. Be proactive to tackle it. There are very significant risks of not replacing our ovarian hormones, okay? And they almost always outweigh the risks of HRT. HRT is much safer than almost anybody thinks. Try to think outside of your bikini and respect your whole body. And even if your risk of breast cancer or ovarian cancer is elevated because of your genes, using HRT does not make that risk any worse. Okay, that's, I think, a really important mindset to get in. If you're going to use HRT, try and use body identical, because it's the most effective and the safest by far, and vaginal estrogen is safe for everybody. And don't forget the testosterone as well, it's really important. And you've probably already seen this leaflet, which I'm sure Joe has, which was written with Louise Newson, which is also really helpful and kind of runs through everything that I've talked about. So I hope that was helpful.
That's incredibly helpful. Thank you so much. There's so much information there that I hope everyone else found that really useful too. I'm going to whiz through some questions now, if that's okay. So we've had a few questions in, both live and beforehand, about how to get the right dose of HRT. I know you said a little bit about kind of trial and error and trying things out, but there's quite a lot of questions about, is there a set dosage of estrogen that a woman, say in her late 30s, 40s, having risk reducing surgery should be put on? Is there, you want to get things right from the start, and that idea of kind of trial and error is a little bit worrying at times, and should we be looking at blood test levels and kind of things to try and be getting the right levels?
Yeah, really good question. In general, younger women need more estrogen than an older woman does, but that's in general. So usually, and the beauty of what we use now with estrogen, with either a gel or a patch or a spray, is the dose is really flexible. So what I say to women is, right, this is a ladder, okay? I'm going to put you on near the bottom or even in the middle of the ladder, and you can climb that ladder as you want to at a pace that suits you. And often our symptoms are a really useful barometer then. So if you're getting hot sweats and flushes, they're so easy to judge. You go, oh yeah, I've only had half as many this week, brilliant, we're on the right track, we'll go up a little bit more. And when your hot sweats and flushes have gone, you're on the right amount of estrogen. So yeah, for some people are just more sensitive than others, so some people we take the dose down a bit, but for younger women they may go up quite high, they may go at levels above what we call a licensed dose, but that's fine. Licensed doses are based on older women that are way past 50, so we can think outside the box and the bikini for this. And blood tests can be really helpful for getting the dose right as well, both for your estrogen level and testosterone levels. So yeah, definitely.
And you mentioned the spray then. I think the spray is something that you don't see kind of mentioned quite as often. And I've had a couple of questions about that, specifically about the dosage of it. Is, we talk about quite specific dosages along the way that kind of match up between gels and patches and things like that. And how does the spray compare to that? Is it a similar kind of dosage pattern?
Yeah, that is a brilliant question, because the answer is so variable. So when it only came out like 10 months ago. It's a really new thing, so we're kind of learning with it, if you see what I mean, whereas gels and patches have been around for so long, we're totally au fait with them. Theoretically, one spray equals 2 measures of gel or a 50 microgram patch in theory, but what we're finding in practice is it doesn't tend to work out like that. Some women it does seem to work like that, some women it's more like for like, as in one spray of of the Lenzetto is 1 measure of gel or a 25 microgram patch. So again, we're just very open about that and say, look, just find your place. Again, think of it as a ladder. If 1 spray doesn't do it, try 2. If 2 sprays doesn't do it, try 3. That is, you know, that is fine to do that.
Brilliant, thank you. And we've had a couple of questions through from women who have had cancer, either breast cancer or ovarian cancer in the past, and that may be estrogen receptor positive, and might be struggling with symptoms. I know you've mentioned a little about kind of lifestyle things and things like that, but if someone is experiencing symptoms and isn't able to go down the HRT route, what would be the best advice for them to do next?
I think it's kind of going back through, it's making sure all the lifestyle things that can be in place are in place, and that's kind of symptoms allowing. It's trying things, you know, like some people will go for CBT or have a course of acupuncture or hypnotherapy and does find that helpful, maybe short term. That can be helpful. I think the main thing is also asking about her symptoms. So we see many people where their main issue is their vaginal issues, and you go, oh no, well, okay, even if someone told you you can't have HRT, that doesn't mean you can't have the vaginal issue. If you make that woman's waterworks, vagina, sex life better, you may actually achieve most of what she needs for a better quality of life. So it's again that thing about who said you can't have HRT. You know, there's no such word as can't in my vocabulary. It's all on a spectrum, and it's not anybody else's decision. It's not the breast surgeon's decision. It's not the oncologist's decision. It's not the person's husband's decision or whatever. It's that woman's decision, and it's her choice to take with the information that she's got. So I want women just to know that, have they thought about everything? You know, and we have, you know, leaflets on our Menopause Doctor website for patients that have had a previous history of cancer, just so that they know that there is an option. This is about informed choice.
Thank you. I think that's really, really useful message for everybody, actually, is like you said, there's no word as can't, and it's an informed decision. I think that's really useful. And another question that's quickly popped up, and I'm aware that we're coming to the end of the time. Could you say a little bit about kind of the supply issues of HRT? It's something that does crop up and I know worries quite a lot of people. And then if, say, you couldn't get your normal brand of a particular item, but a pharmacist could get you a different one, does that matter? Is there kind of comparison between brands?
Yeah, I mean, it has been an absolute travesty, the 12 months prior when almost everything disappeared. Just awful. I mean, you know, the menopause is hard enough for women without having to cope with that sort of thing. Most of that, almost all of that problem is now gone. So virtually everything that we needed back again has come back. There's a few little things, but to be fair, the things which went AWOL were the older fashioned types of HRT. So it never actually affected us very much, apart from that we had to keep switching people from brands of patch. It didn't affect us that very much because we only prescribed the body identical stuff, and that does not have any problems associated with it. And cross fingers that won't be the case either. There is a lot of resource out there now, like on our website or on the British Menopause Society website, of equivalent doses, what you can swap to and from. And so there is always a way around it with somebody that understands what they're doing with it.
Brilliant. I think that's really, really useful to know, is that not to panic and to try and speak to an expert, and there's probably a way around it. I think that's a really, really useful.
Yeah, don't go cold turkey. Yeah, don't do that.
No. Brilliant. Thank you so much. I'm aware that we're just a little bit over our time, so I know that there's some questions that haven't been answered. I'm really sorry, everybody, but I hope that there's been a lot of content in the presentation just there that probably answered some of those questions that were sent in beforehand or at the beginning anyway. That was so informative. I've learned so much. Thank you so much for your time. It's really kind of you to give your time to help us out like this. I will be sending out the recording of this later, so hopefully anyone that missed anything or needed to make any notes, we will be able to get that to you later. So thank you so much, and hopefully see some of you again soon. Thank you so much, Sarah.
Thank you, Jo. Thank you, everyone.
Thank you. Bye-bye.
Bye.